Welcome to National Kidney Foundation Spring Clinical Meetings 2013. I'm Kenar Jabari, part of the eAJKD blog, the official blog of the American Journal of Kidney Diseases. I'm here with Dr. Muriithi. She's from Mayo Clinic. She's a fellow, a nephrology fellow there. Congratulations on your poster that talks about drug-induced chronic, acute interstitial nephritis in the elderly. Can you tell us a little bit about that poster?
Yes. So how it started really, first we were looking at all patients with biopsy-proven AIM, and we did from the years 1993 to 2011. And in the whole hospital, in all ages, we got 133 patients. So we wanted to look more deeply into the elderly patients who were 45 of that cohort, about a third. And the reason being because there's been a lot of literature that they probably are more susceptible to drug-induced, especially from NSAIDs. And there was a recent study published from a registry in Spain last year that suggested that in the elderly, the prevalence is actually skyrocketing. Now, they weren't sure whether it's because more biopsies were being done or they're just being given more drugs, or it's actually an increase in the prevalence of AIM. So we wanted to look at this age group, 65 and older, and see what exactly were the causes and how are they faring compared to the younger ones. And what we found really is that the elderly patients, overwhelmingly, their AIN that they have is due to drugs. So out of 6 patients with AIN, if they're older than 65, 5 of them will be due to drugs. So the percentage was about 84 compared to just 64 with the younger. And the elderly were very unlikely to have autoimmune diseases. So in the entire elderly cohort, only 3 people had autoimmune diseases, whereas for the younger patients, it was the second most common after drugs. And then when you look more deeply even into the specific drugs, seeing as 84% of the elderly had drugs, so not surprisingly, antibiotics were at the top of the list, with penicillins being the most suspicious. But surprisingly, we had the second most common group was PPIs, proton pump inhibitors, which came as a surprise. There's been literature that it's because of the prevalent use of PPIs that the incidence is increasing of AIN, but we really were surprised by just how much powerful it was. Of course, the most common culprit was omeprazole, just as has been reported in the literature. So it's whereas NSAIDs were actually a very distant third, which came as a surprise because the thinking is that the elderly are the ones using the NSAIDs, but surprisingly the NSAIDs were more common in the younger people. So it was interesting just to look at exactly what the causes are, and then see how exactly they're presenting. So the elderly were a lot more likely to have very high serum creatinine, a lot more likely to need dialysis, and a lot more likely to have fibrosis on the biopsy at the time they had the incident. And when you compare specifically the PPI to the antibiotics, they had very long duration of being on the PPI compared with the antibiotics. And because of that, they had more fibrosis, more glomerulosclerosis, and they were less likely to recover. So they might not have had very dramatic increases in creatinine as would occur with antibiotics, but they'd have a very slow simmering underlying chronic damage that then would mean that they don't recover as well. And some of them would have the PPI on board for even up to a year before they actually had the biopsy and it was found that this is probably the cause. So it did come as a surprise just how prevalent PPI is and how important they imagine as a cause in all patients and especially the elderly.
So in terms of treatment, now these elderly patients who are on drug-induced AIN, if I stop the offending drug, what is the evidence of treating them with steroids? And would you suggest treating them with steroids and how long? And would you give them any prophylaxis like Oscal and vitamin D, calcium, if you treat them with steroids?
So in our study, we found that of the elderly patients who had drug-induced AIN, actually all of them except one were treated with steroids. So it is a retrospective study, but there seems amongst clinicians not to be a hesitancy to give them steroids. So they were treated with steroids, but because our study is retrospective, we weren't able to see much incidence much difference in whether they recover or not because only one patient was not treated. But as compared to the younger patients, there was no difference in recovery. So they seemed to recover. And the evidence really so far, there's still not a single prospective trial really that we have looking at steroids in any age group, and what is going to be the benefit of giving steroids. So it's still a very hard question to answer. The one study that did look at steroids retrospectively showed that if you delay too long after the injury occurs to start with steroids, then they're more likely not to recover. But that doesn't mean, as we saw in our study, the people who are given steroids tend to be sicker when you look at the whole group, so there's still some selection. So it's unclear if you look at a prospective trial what's going to happen.
Yeah.
So there really is, I think I would say for now, just treat them as you would the other patients. They have a good chance of recovery. Most of our patients, even in the elderly, 25 out of the 30 did recover some kidney function, although they were more likely to end up with chronic CKD. And as for prophylaxis, we really don't have much data. Most of the time they have short-term period of antibiotics, of steroids, and most of the time they would have some other indication. You have osteopala vitamin D. So I would suggest treat them as the Institute of Medicine recommends as far as that is concerned, but we've not really had much data or experience with giving them prophylaxis specifically during the period of treatment for AIM.
You think the internal medicine community needs a little bit more education on proton pump inhibitors as a renal toxic medication, especially now in the elderly?
Oh, absolutely. When you look at, there was a report a couple of years ago on just the rise of use of all kinds of drugs. So all kinds of drugs are being used much more than they were 10, 20 years ago. And PPIs have really skyrocketed. And a lot of times, therefore, indications that were never really meant to be, they've been used for things that were never really meant to be used for. And because people have this underlying feeling that it's not such a big deal to be on a PPI, they don't really look at why is the patient on it, how long has the patient been on it. So absolutely, and especially the elderly people, most of them are going to be on PPIs for some reason. And you're going to have a slow simmering kidney injury that may not make you suspect AIN, and you'll keep them on the PPI and they continue having the injury. So I think there does need to be some recognition that this is not, they're not innocuous agents, and you need to decide whether they really need the drug, and if they're having some slow simmering kidney injury, look at the PPI.
Well, thank you again, and thank you for joining us on eAJKD.
Thank you.